Our next speaker is Melissa Watt. Melissa is Associate Director of the SBS Corps and a small grant recipient, and the recipient of a recent R21 that was awarded last year. Melissa?
Thank you, Kent. I think what's unique about the CFAR is you can have a panel where you have cellular research on zebrafish and qualitative research on pregnant women in South Africa in the same panel. So I'm going to speak about the small grant that I had through the Duke CFAR and how that has transitioned me into a funded R21 in Tanzania on a similar topic. So this is on postpartum HIV care engagement in the context of Option B+ guidelines. And what got me interested in this research area, which was new to me when I got the CFAR small grant, was a change in policy regarding PMTCT, prevention of mother-to-child transmission of HIV, guidelines globally. So it used to be that for the prevention of PMTCT, the focus was really on prophylactic treatment for women to prevent transmission to the child during pregnancy and breastfeeding period, with initiation for the woman only if she met criteria, clinical criteria for initiating under whatever national guidelines existed. Based on CD4 count or opportunistic infections or WHO staging. But in 2014, there was a transition then to new guidelines that were called Option B+. And with that, within those guidelines, women who are initiating antiretroviral for who are HIV infected and either pregnant or breastfeeding would initiate antiretroviral treatment for lifetime use regardless of their clinical staging. So this started in 2014. Malawi was the first country to roll this out. Later in 2014, Tanzania initiated this, and then in 2015, South Africa, and now it's guidelines for the majority of countries in Africa. And I think really is a precursor to what we're now seeing with a test and treat protocol in many countries. And so when we think about the delivery of HIV care services, we typically think about it in terms of this care cascade. And we look at areas where within this continuum, we lose individuals who may be HIV infected. And what we want to see is uptake of HIV testing, diagnosis, and then linkage to HIV care, retention in care and engagement over time, including adherence to medication, which then leads to virologic suppression and eventually to the reduction in further transmission of HIV. And so we're interested in this, and sort of this is kind of how we think about supporting HIV treatment programs across any population. In the case of pregnant women, though, it's particularly challenging because you have all of these other life contextual issues related to pregnancies, related to childbirth, and then you have the urgency, of course, of needing to initiate treatment quickly and to be retained on treatment, particularly through that early period when transmission to the child is a possibility. So there are a lot of factors that could impact retention across the PMTCT continuum. At a personal level, of course, you have the stressors of pregnancy and having a new child. Also, this combined with HIV, of course, and oftentimes a new diagnosis, because many women are getting tested within the context of antenatal care. Mental health issues in terms of perinatal depression. The focus on the baby as you transition sort of from pregnancy into the postpartum period, that self-care, as many new mothers know, is not always prioritized and not always space to prioritize that. At an interpersonal level, of course, there are a lot of partner issues. issues around social support, violence, fears around disclosure and stigma, and I'll be speaking more about that. And also, particularly in many of the contexts where I work, issues around migration, that women might travel either in the pregnancy period or in the postpartum period in order to be closer to family, or places where they would prefer to give birth or to raise their child in the early period. At a clinical level, as I mentioned, this urgency of ART initiation, the integration between services. Women are getting tested in antenatal care. They're getting perinatal services within reproductive and child health clinics oftentimes. Then after they give birth, they of course go to the labor ward to give birth. They need to have their HIV managed in the labor ward. They come back with the new baby, they're getting well child checks. And then of course, as they transition out of the postpartum period, are going into adult HIV care. So there are a lot of different transitions that women have to make that we need to keep an eye on. Overcrowded and long waits, that's sort of typical of many of these places. And at structural level, poverty, unemployment, and just ideas of future prospects. So based on this, I developed a study to begin to explore some of these issues in the context of South Africa. At the time, it had been implementing Option B+ guidelines for just under a year. And so I received a CFAR small grant that was purely qualitative in nature. And we had an ongoing clinical relationship at Umzamukhle Clinic in Cape Town, where we had, with Kathy Sikkema, collaboration I had with her, she had an ongoing R34 study there. So we were able to kind of get the benefit of having a clinical infrastructure and a research team that we could use some of the efforts on, which really made this a feasible grant for a small amount of money. So we did in-depth interviews with women who are initiating lifetime ART during pregnancy under Option B+ guidelines. We did repeated interviews, first in their third trimester of pregnancy and then 3 months postpartum. We did in-depth interviews as well with patient supporters if the woman was able to and willing to refer a patient supporter, either a partner, a family member, friend, etc. And we also did some key informant interviews. So the characteristics of the 20 HIV-infected pregnant women that we enrolled, it was a low socioeconomic status, less than half were employed. Only 15% were married. The majority were in either unstable relationships or non-married relationships or single. For most, it was not their first pregnancy, and almost all were newly diagnosed with HIV. So in terms of what they saw as their motivators and facilitators to remain in care, there were sort of 3 primary themes related to children, staying healthy, and having support. So children, obviously women were motivated by not wanting to transmit the virus to their child during pregnancy, during breastfeeding, and for themselves of wanting to be around to be able to support the child, watch the child grow up, etc. So sort of children was a huge motivator for women to stay in care during, at least when they were thinking during the pregnancy period. They were also motivated, of course, to stay healthy themselves, to live a long life. Interestingly, they were really motivated of wanting to prevent being identified as sick with HIV. So there was sort of a recurrent theme that people said, well, if I take the medication, no one will know I'm HIV because I'll remain healthy, I'll remain having vitality, and people won't identify me as having HIV, so I can keep my status hidden. They also, and this is very, I think, specific to South Africa, that HIV is so prevalent in South Africa that everyone we spoke to had known a neighbor or a family member or someone who had lived with HIV and now had benefited from treatment and sort of, had a long, normal life. So there was a real role modeling, I would say, of being able to live with HIV and live a normal life. So that also became a motivator to take medications. And support, reminders from others after disclosure, and positive interaction with healthcare workers were things that were mentioned. But at the same time, of course, there were barriers to care engagement and adherence, and at all the levels I was speaking at before. At the personal level, issues around motivation. At the interpersonal level, issues around stigma and disclosure, which I'll speak more about. At the clinical level, waiting times, just being able to access the services easily in a way that fits in with one's life. At a structural level, again, sort of missing out of school, missing out of employment, et cetera, for being able to come to the clinic and kind of continue those activities. But what recurred most frequently across all the interviews was this issue around disclosure, particularly to the partner. And so partner non-disclosure, there were sort of three primary themes within that. One is that during the pregnancy period, pregnancy really became a cover for being able to take one's medication. So this woman said about her partner, he reminds me, it's 8 o'clock now, come and take the baby's pills. The pills are for making the baby grow, dear. But I know, like, my God, if you only knew what these pills are for, it's really difficult. So women talked about during the pregnancy period, they could kind of keep these pills, keep the intention and the purpose of these pills secret, but that they were worried at that time about what that would mean in the postpartum period. Of course, partner disclosure, there are also higher stakes. So, disclosing at any time, of course, is challenging, but when you're pregnant and you risk losing a partner, losing support for the baby, losing a father figure in your child's life, it's very high stakes. So this woman said, by telling the boyfriend could run away, leaving the responsibility behind. In other words, the responsibility for caring for the child. And then not having disclosed is really created amplified stress for women. So non-disclosure stresses me a lot. You have a baby with this person and yet you have secrets. So it creates this tension within the relationship. And all of these issues around partner non-disclosure creates risks for defaulting. So as this woman said, this boyfriend, he didn't know I was taking ARVs. Because I hid my status from him, I could not take them as prescribed and I couldn't attend my clinic appointments, so I stopped taking ARVs. So it's a sort of, this woman was talking about this trade-off between staying in HIV care or staying in and continuing to sort of invest in this partnership. So the implications and the recommendations of this, of course, there are opportunities for partner HIV testing, and we've seen this. Certainly, I'll tell you a little bit about my work in Tanzania, but partner HIV testing there is certainly very stressed, as is male engagement in PMTCT, but comes with other challenges as well, and the need for counseling for appropriate and safe disclosure. So that's just some of the preliminary findings that have emerged from our South Africa work. Anybody who's worked with qualitative data knows that the data analysis process takes quite a long time, so we're sort of really just at the beginning of that process. But what I want to transition now and speak about how this small grant sort of helped me to transition into an NIH-funded R21. So I received the grant, I think sometime in the spring of about a year and a half ago, and I had the grant. We were still sort of trying to get all the ethics approval, and with the small grants for the international work, it takes a little extra time. And so everything was sort of still getting processed. We hadn't even started collecting any data yet. And then there was an RFA that came out that was looking at, it was an RFA for NIH-funded research to inform implementation science and build capacity for implementation science to support PEPFAR. And based on having written this small grant, I was really excited to potentially do something related to that. It was corresponded with the time that Blandina Mbaga, who was visiting, she's a Duke partner, a DGHI partner at KCMC and the director of the Kilimanjaro Clinical Research Institute. She was here. We sat down and had a brainstorm, and we said, oh, let's, she was excited about this idea, and we said, let's do something related to this issue of postpartum HIV care engagement. So I didn't have any funding. I didn't have any results yet from the South African study, but I would say that nevertheless was still, I think, really I attribute to my success for the R21 application, because they were impressed at having had already built this collaboration, already have funded research in this area, even if I didn't have the results yet to share. And having written the CFAR small grant, I pretty much had my significance written and, you know, some nice sentences within my specific aims that I could then feel confident to kind of bring together and write this R21 application. So, the research got funded in 2016, and the research goal here was to examine the implementation of option B+ in multiple clinic sites in the Kilimanjaro region of Tanzania. So it was an implementation science RFA. And matters because to support the implementation of option B+ by informing scalable intervention. So what can we do to really improve implementation? What are the points of implementation that can be improved to support women's long-term care engagement? So we are working now in Tanzania across 9 facilities in both Moshi Urban and Moshi Rural. And we have 3 aims in the study. So it's purely observational study at this point with the goal of informing intervention development. So the first is looking at facility level factors of the option B+. So I had a master's student in global health who was there this summer, and really, she's a Kenyan physician and was able to really lead this piece around facility level factors. So we did clinical observations across 3 sort of selected clinical settings in order to look at patient flow, staffing, and environment. She did key informant interviews with 30 key informants across the 3 sites. And then we're also at the same time, and this is with a Doris Duke Clinical Fellows, a medical student at Johns Hopkins. We're doing a record review of the CTC, the Care and Treatment Clinical Sites, their database, to look at long-term retention of women who initiate ARVs under option B+. So together, this is really going to help us understand this facility level side. We're also looking at patient level factors. So we have a cohort of 200 women. We just finished enrolling our cohort a couple weeks ago. We had proposed in the grant 100 women, and the team was like, no, we can do more than that. So we sort of increased our clinical sites, we increased our team, and we were able to recruit 200 women into the cohort. We do a baseline during pregnancy. Follow-up surveys at 3 and 6 months is what we had proposed in the grant, and now we're sort of planning a 12-month follow-up, and possibly, if we are able to get some supplemental funding, to go longer, because I think looking at the transition from PMTCT care to adult HIV care is very important. We're also getting ready to do a medical record review of clinical medical records to confirm care engagement, and then also just to understand sort of how things are documented in the clinical records, which I think has really important implementation lessons. And we are doing HIV viral load testing at 6 months postpartum. So this was something that was proposed that we would collect from the medical record viral load data at 6 months, but it turned out that viral loads were not being done consistently. That's kind of changing as the policy rolls out, but we decided to actually collect our own viral load data. And then we're also doing qualitative interviews. So this is very similar to the work that we're doing in South Africa, in-depth interviews during pregnancy and follow-up in-depth interviews at 3 months postpartum, in order to really understand kind of those narratives of care and the patient experiences. So this is just an example of the sample participant timeline. And then aim 3, which we'll be doing towards the end of the study, is to identify opportunities to improve implementation. and we'll be doing focus group discussions and stakeholder feedback meetings. But we have already begun this process as well. So when I was there in May, we actually held a stakeholder meeting in the Kilimanjaro region and brought together both KCMC investigators who were doing research on option B+ or on PMTCT, as well as policymakers and clinical providers and other stakeholders. So we're, trying as we go along to really sort of build those conversations and build those networks. And so our next step then is to use data to inform interventions. We see opportunities for intervention certainly at the patient level in terms of support and mental health treatment and care models. At the facility level, how do we sort of improve patient practices? And at the provider level of how do we improve counseling and patient-centered care. There is a new RFA that's come out about reducing stigma to improve HIV prevention, treatment, and care. And we're beginning to discuss as a team how we might sort of look at that and inform, take what we're doing and allow that to inform an HIV stigma reduction intervention in order to promote long-term care engagement. So we have some ideas for that. So I just want to thank the teams of ours at UCT, in Cape Town, at KCMC, in Moshi, and here at DGHI. And I'll take some questions.
Time for one question. In the back.
Hi, Melissa. I actually have a question for you. Any plan to do a pulse course here in the U.S.? Because it seems like so many of these issues are also issues that we see in our pregnant HIV-positive women.
Yeah, I haven't explored that myself. I would certainly be interested in having those conversations, but we're not at we haven't at this point looked at kind of doing any type of comparison. But I do think it'd be interesting, and you're absolutely right. I mean, if I think about that list of kind of the things that I talked about of the factors of influence, I mean, it's pretty similar. Thanks, Julie.
Thanks so much. I think you're kind of the poster child for how these small grants are supposed to beget bigger grants. So thank you so much.